Hi, everybody. So now we'll have this opportunity to talk with Dr. Alessandro Villa to share some thoughts and some questions. So, Dr. Villa, thank you so much for your talk. It was really a good update in the subject. Dry mouth is a really complex, important complication, as has a great impact in patients' quality of life and has a multifactorial causes in many cases. As I said before, I think it's not always well valued in an appropriate manner, so the correct diagnosis achieved. And I also think it is frustrating many times as the treatment is not always 100% resolutive. So I will start with a question about the pilocarpine, as you mentioned in your lecture. Sometimes it has side effects that the patients cannot tolerate. And so what would you do in these cases? What would be your approach?
Yeah, thanks so much for the question. That's a good point. Pilocarpine does come with side effects in some patients. Usually sweating, nausea are the most common, and increased urination. The pilocarpine is a sialolog that acts on the muscarinic receptors. In some cases, switching to a different one, like cevimeline or bethanocol, may actually result in less or no side effects because even though they're all muscarinic receptor antagonists, they act on different M receptors. So in some patients, for example, switching from pilocarpine to cevimeline may do the trick.
And which is the best posology that you experience using pilocarpine?
So as a starting dose, it's recommended to start pilocarpine 5 milligrams 3 times a day. Pilocarpine also comes as a 7.5 milligrams tablet. So if patients have an initial response, but you're not satisfied with the increase of amount of saliva and improved xerostomia, it's also possible to switch to the 7.5 milligrams. But in general, the recommended dosage is 5 milligrams 3 times a day throughout the day, so morning, lunch, and nighttime.
Okay, so we have already a question here in the chat that I'll read for you. Constanza Marin is asking if there is any evidence of alteration in the salivary pH after the chemotherapy.
So that's a great question. It also depends on the type of chemotherapy that we are considering. So the normal salivary pH usually ranges between 6.2 and 7.6. It's also something that sometimes is challenging to evaluate because even drinks or food can change the pH of saliva in general. So for example, when bacteria break down carbohydrates that we eat normally in our diet, this lowers the pH levels of the saliva, but it also depends on the drugs of the chemotherapy that we are considering. So for example, you saw in my presentation that immunotherapy does have an effect on salivary gland tissue, but the way immunotherapy works is basically by creating an autoimmune reaction against the salivary gland tissue, whereas if we consider a medication given as an IV chemotherapy that is known to cause hyposalivation and xerostomia, that's all a different story because we are considering 2 different mechanisms of actions. But it's a great question. It depends also on the drug that we are considering.
We see that during chemo, there is a reduction in the salivary flow, but then the patient will recover, right? Does it work also for the immunotherapy, or
That's a great question also. Not, unfortunately, no, because it goes back to the mechanism of action.
Yes.
In immunotherapy, one of the side effects is hyposalivation, which is due to an autoimmune destruction of the salivary gland tissue, which is in a way similar to what we see in patients with Sjogren disease. Whereas in a conventional chemotherapy or in other drugs that do cause dry mouth, the mechanism of action is completely different. So, for example, if you consider a diuretic and antihypertensive, it's because patients are eliminating the amount of water through urination, and therefore they also develop dry mouth. When they stop the diuretic, the salivation improves.
Recovers. Mm-hmm.
In immunotherapy, when you stop immunotherapy, if the patient had developed these side effects, unfortunately, it tends to continue over time. It becomes a chronic condition.
Yeah, yes, as we said before, also as the immune therapy is advancing, probably we'll see more of that in the future, right?
Correct, yeah.
So I have a question here from Luciano Castro. He says, congrats, Dr. Villa, for the excellent lecture. My question is, what is the role of imaging exams, especially ultrasound, in evaluating the functional parenchyma of salivary glands in patients with hyposalivation?
So that's another excellent question. I'm not an oral radiologist, so I'm not an expert in this, but I know that salivary gland ultrasound has been used, for example, for the assessment of the submandibular gland and parotid glands parenchyma, which is a non-invasive procedure, and it can be useful, for example, in patients with Sjogren's syndrome, especially because they are at a higher risk of developing a secondary non-Hodgkin lymphoma of the salivary glands, in particular the parotid glands. So it may be useful, for example, as a differential diagnosis or to identify any pathology of the glands in patients with Sjogren's syndrome. I'm not familiar with the use of ultrasound in the clinic to evaluate the salivary gland parenchyma in patients with cancer, but thanks for the question.
Okay. So we also have another question from Manuela Carrera. She's asking how you deal with polypharmacy cases. Easy question.
That's a tough one because polypharmacy is really the top cause of xerostomia and salivary gland hypofunction in some of these patients. So in general, I manage these patients by starting to provide symptomatic relief and looking at patient-related outcomes, in particular, if their xerostomia is improving with over-the-counter moisturizers, salivary gland stimulants, for example, chewing sugar-free gums with mechanical stimulation of the salivary gland. If the next steps would be the use of sialogogues, for example, we talked earlier about pilocarpine or cevimeline. And if the patients do not respond at this point, you may consider discussing with the primary care physician if there is an opportunity to switch to maybe a different antihypertensive, or it gets a little tricky sometimes. But I have to say, most of the times, patients do well with over-the-counter moisturizers, increased water intake, and sialogogue therapy.
Great. It's very challenging, right? Because sometimes you cannot change the medicine. Right. The doctors are resistant with some medications that they are used to prescribe. And I have someone in my door, but that's okay. I'll just ignore. And my dog will start barking now. So I have another question from Lillian Brau. She's asking about eye drops. Do you use eye drop as pathology for pilocarpine?
That's a good question. I personally don't use it. It comes as 1.25%, the drops. I know in some country pilocarpine is not used, is not available actually for the management of dry mouth, but it may be a good opportunity if the drops are available to use the drops, considering that the concentration is a little different, as I said earlier. But it's definitely, there's also pilocarpine eye drops at 4%, which is a higher dosage, and it could be prescribed because these are usually prescribed to be taken by mouth also. So it's definitely another way to do it, yes. There's also some studies that show pilocarpine used as a lollipop, so where patients actually suck on it. So there's different options, but absolutely the eye drops in case there's no tablets available, are definitely a good opportunity.
Okay, great. I have another question here from Sonia Ferreira. She says it's a little out of the subject, but I think not really. She's asking about the frequency of psychological effects associated with xerostomia and hyposalivation in your experience.
I love this question, and I think in my presentation also I briefly touched upon this, that patients, for example, undergoing therapy for head and neck cancers or cancers in general may develop anxiety and depression, obviously because of the cancer. But there are so it's almost like a vicious cycle, in the sense that a patient undergoing cancer therapy may develop anxiety and depression, which we know have an effect in reducing the salivary flow rate. They also have an effect on xerostomia in general. So it's hard to tell which one comes first. Is the chicken and the egg? Is it the xerostomia because of anxiety, or is it the xerostomia because of cancer therapy, or it's a combination of both? And definitely dry mouth does have an effect also in non-cancer patients in terms of psychological issues and quality of life in general of these patients, especially with severe cases of dry mouth. Without opening a Pandora box, patients, for example, with burning mouth syndrome may complain of a feeling of dryness in the absence of salivary gland disease. So they may have plenty of saliva yet complaining of xerostomia. That's another perfect example of how comorbidities like anxiety and depression can also have an effect on how patients perceive their saliva in the mouth.
Yes, and also it may add another medication in the treatment that you also potentialize. And it's, as you said, is a cycle, right?
Right, correct. That's a great point.
So I have another question from Luciano Castro again. In your experience, what is the best therapeutic option for managing dry mouth in patients with Sjogren's syndrome? What works more, drug or no drug therapies?
That's a tough question. Also, in general, these patients, as you know, with Sjogren's disease, several of these patients have very, very little saliva. And I think that initially they would benefit from at least Sialolog therapy, although not everybody responds to pilocarpine or cevimeline. And so over-the-counter moisturizers have obviously play a big role, and there's a laundry list of products available with different efficacy. And there's also obviously the underlying treatment of Sjogren's disease. Sjogren's disease is a multi-organ syndrome, so it also depends on what other medications the patients are taking. Are they on hydrochloroquine, or are they on rituximab for severe Sjogren's? It depends on that as well.
Okay, great. So I have another one from Luciano Azevedo. He says mucosal lubricants are the only possibility to minimize dry mouth in cancer patients whose submandibular glands were surgically removed.
No, no, in the sense that, as you know, there are other major salivary glands like the parotid glands and the sublingual, and we also have the minor salivary glands. So it depends on which glands was surgically removed, but we can take advantage of the remaining salivary gland function of other glands. And so I think that if the patient is a good candidate for Sialolog therapy, even though the patients do not have submandibular glands, they would still benefit from it, because even the parotids have M receptors like M3, for example, for pilocarpine. So it would, I think it's worthwhile still prescribing them and see how they respond.
Okay, so I'll take advantage of our talk previous, as you were saying something about gene therapy for the treatment of dry mouth. So could you say something more about this for us?
Yeah, of course. And apologize for the background noise. My neighbors are doing work, of course.
No problem. We can hear perfectly.
So yes, there's some animal studies that were conducted in the past using gene therapy, specifically aquaforin-1. And now there's a company that just completed the phase 1 trial. This is public knowledge. It's available. And this is with aquaforin-1 gene transfer for the management of xerostomia secondary to radiation therapy for head and neck cancers with some promising results. And now there's an open phase 2 trial looking again at aquaforin gene therapy for patients undergoing radiation therapy for head and neck cancers. And in a nutshell, gene therapy uses a water-specific protein called aquaforin-1, which has the potential to increase the water permeability of the salivary gland duct, therefore potentially increasing the amount of saliva that patients have in their mouth. So I think that this is very exciting. We are all excited to see what the phase 2 clinical trial results will be, but there's definitely hope for the future.
So this is more for head and neck radiotherapy. Do you think it would work as well for immune therapy?
That's a good question there, because
it's different mechanism, right?
Yeah, but there's some studies looking at, for example, Sjogren disease and the role of aquaforin that are promising, at least animal studies. So if we think about salivary gland dysfunction secondary from immunotherapy, in a way, a little similar to Sjogren disease. So possibly, I think that the focus now is head and neck cancer patients, but I'm sure that the goal is ultimately to deliver the aquaforin gene to the parotid also in patients with other salivary gland diseases.
But although it seems promising as a therapy, it'll be not available for everybody, right? Gene therapies are expensive, right?
Yeah, and also we're talking about research right now, right? Gene therapy is used to prevent several diseases, and but it's not yet approved, at least this one, for salivary gland diseases and hypofunction in general. So I think that it will take a few years before it's available, but hopefully soon.
I think the first gene therapy approved was in the UK, right? recently. So
you caught. I don't want to tell you one thing for the other. I think it was approved for CRISP disease, for diseases. Yeah, for some diseases. I think it was called CRISP, maybe CAS9 gene, but don't quote me on this one.
Okay. Well, I think we are approaching our designated time. So I want to say thank you for your great lecture and for your time here to answer these questions. I say I learned a lot, and I promise I'll be more stimulated to treat these patients. As I said, we see many patients with dry mouth. I am always frustrated. I think it's really disappointing because we know how it affects patients. So it's great to hear that there's a lot of studies and promising drugs for these patients. So thank you for bringing this knowledge for us. And thank you, everybody, for watching us. And I think as we are on time, the next talk will start 13 is, as we say here in Brazil, 1 p.m. And thank you so much, and have a great event. A great afternoon, everybody.
Thank you for having me. Bye-bye.
Bye-bye.